Thank you, Len, and for Norm for organizing this and for inviting myself and Dr. Catherine Courtauld. I'll just quickly do an introduction. I'm a clinical nurse specialist who's semi-retired, and I've been working in palliative care for almost 30 years. And we will make an attempt to really try to give you some resources and give you a better understanding of what palliative care is. And I'll just let Catherine quickly introduce herself before we start, because I have to get my presentation back on.
Hi, I'm Catherine. I'm a palliative care physician. I work at Vancouver General Hospital and Burnaby Hospital. So it's really great. Thanks for inviting us. We're excited to share what we know about palliative care. And I think it's often a taboo term or something that people don't know a lot about or don't want to know a lot about. So thanks for inviting us. I think that's the first step, and we're looking forward to also answering questions that you might have afterwards.
All right. So why are we here today, besides the fact that Norm and Len invited us? And it's really looking to help you build upon what you learned. And I understand you had a session on advanced care planning, so we want to learn to build upon that and to really help you reflect on your journey. All of you are dealing with prostate cancer. And so how can you look at the best ways to live as well as you can for whatever time you have as you're dealing with this illness? And what we talked about, to understand what palliative care is and what resources can be accessed as you need them throughout your illness. So there are many people who are on your team. You have your family physician or your nurse practitioner. You have the Vancouver Prostate Center. You have the different BC Cancer Agency teams. If some of you are from the Valley, certainly there's teams there. You may have other specialists or healthcare professionals, such as your urologist. You have your family, you have your friends, you have your support group. So you have a lot of people on your team who are there to walk this journey with you. So what about palliative care? So today we're hoping to answer, what do you need to know? What do you need to do? And how is the best way to prepare as your health condition begins to change? Now, I'm going to put on, so I think I have to stop the screen share. I'm going to put on this video that I'm hoping that you can hear, but I did put the closed caption, and I'm sure Mark will help out if we can't hear it. So I'm going to stop sharing that. I'm going to find the video and hopefully be able to share that. And I have to share computer sound, so hopefully that's going to work. So let's see if I can play this video for you. And hopefully you can hear it.
What comes to your mind when you hear or see the word palliative? Many people, appropriately, think of words such as compassion, dignity, or quality of life. However, for many people, what comes immediately to mind are the words dying, terminal, and end of life. Unfortunately, too few people think of palliative care alongside treatments to control the disease.
I'm Dr. Gordon Giddings. I'm a palliative physician at the University of Ottawa and clinical content editor of Palliative Canada. The aim of this Palliative Doodle is to explain that palliative care is not something for just the last days or weeks of life, but should be initiated much earlier.
To better understand this, let's look at the illness trajectory starting at the time of diagnosis of a life-threatening illness. In some cases, the disease, whether it be cancer or another non-cancer disease, can be cured with treatments. In other cases, however, the disease may be incurable. Let's draw a graph around this journey. On the x-axis is the length of that journey from diagnosis to death. On the y-axis is the goals of care, the treatment and care options in focus. Now, unfortunately, because people often think of palliative care only for the last days or weeks of life, they will only activate a palliative care approach in the last days or weeks of life. Let's look at the negative consequences of this. They include lack of symptom control with unnecessary suffering, inappropriate treatment choices, prolonged psychological distress because no one is addressing the fears and concerns of the patient, lack of discussions about prognosis, or lack of preparation regarding care choices and treatment goals. So what do we need to do? Well, We need to erase the old model of palliative care and use a different model, a different approach. What if we start palliating early in the illness? This does not mean that treatments to control or cure the disease and palliation and supportive care are mutually exclusive. The model of early palliative care is much more patient-centered and responsive to patient needs. Is there evidence to show that early palliative care is better than late palliative care? In a large US-based study by Timmel and colleagues, the model of early palliative care was compared to the usual or common model of palliative care, only in the late phase of disease. What do you think the results were? Which group do you think did better? Which group had less depression and less anxiety? Which group had better quality of life and symptom control throughout their illness? Which group do you think lived longer? The early palliative care group experienced significantly less depression and anxiety, better quality of life, better symptom control, and astoundingly, they lived almost 3 months longer than those patients who received only late palliative care. So the key message is palliative care early is better than palliative care late.
I'm just sharing back the PowerPoint, and I think we were about here. So things that in this video, some things to remember is that there are myths out there about palliative care. There's a myth that palliative care is only needed when you are dying. It means that I can't have any more treatment. That's another myth. And there's a perception that my doctors and my specialists have given up on me. But in reality, it isn't, because people feel that when you're referred to palliative care, there's no hope left. And Catherine and I, at anything, is that we give hope to people, because it is really an approach, what the video says, is alongside a treatment. So you can receive good palliative care as you are receiving treatment. And it improves quality and quality of life and quantity. You saw that they said with that research study, people actually lived on an average 3 months longer. And we in palliative care actually firmly believe that if we can get your symptoms under better control, your body's under less stress, and you do have a better quality of life. And when your body is less stressed, you tend to hopefully live a little bit longer. It also helps you plan based on your wishes to really understanding what's important to you. You do hear a lot of doctors say, oh, this is the treatment, this is what you're going to get, this is what you're going to get. And for us in palliative care, we try to understand what's important to you so that we can say, okay, now that we know what's important to you, these may be the options that would fit what's important to you, so we can move ahead with that. So that's something to think about when you're thinking about palliative care. Catherine?
Yeah. So really the definition of palliative care is a holistic approach to care when a person has been diagnosed with a life-limiting illness and can benefit from good symptom management, psychosocial and spiritual support, and bereavement care for loved ones. And so really it's an approach for increasing people's quality of life. So we work as a team with your cancer specialist or your non-cancer specialist in people that don't have cancer, but other life-limiting illnesses. And often we work very closely with your oncologist, your urologist, your radiation oncologist. And while their specialty is radiation therapy or giving you chemotherapy or giving you your hormonal treatment, our specialty is making sure that you're comfortable and that your symptoms are well controlled while you're getting those treatments. So it's really a teamwork with the other professionals you have in your life. And we also really believe in treating the patient and the family or loved ones as a whole. So we'll also make sure that we support your loved ones in whatever they're going through.
So we have one more video, so I'm going to stop share here and find my other video.
I must say, Ingrid, your skills have exponentially improved through the presentation.
Oh my goodness, I'm always worried that I don't have the right thing put up, but here we go. Can everyone see this video? Okay, perfect, thank you. Here we go.
Hi. We got a call that this house is on fire. How can we be helpful? Well, the house is on fire, but I'm worried if you go in there it might send the wrong message. Wait, what? I'm with the fire department. Yes, I know. I think you could be really helpful, but I think the family might be worried something is wrong if the fire department shows up at their house. But something is wrong. Their house is on fire. Do you think there's any way you could talk to them, but not use the word fire? What? I just think if the family hears the word fire, they might lose hope. But I am with the fire department and I am here to help this family with their fire. Right, totally. I think you could be really helpful, but I'm just not sure this family is in a place where they're ready to meet the fire department right now. Can we call you the water support team?
Okay, no, I didn't get that one yet. Hang on, let me try to get it back. Where did my slide go? Here we go. All right. Oh, now I'm not moving from current slide. See, Catherine, you jinxed me. All
Yeah,
right,
so
there we go.
that was just to talk a bit about the taboo around palliative care because it's something that people don't talk about often, and it's a relatively new field. And historically, it was more around end-of-life care, and more recently, studies are showing that early involvement of palliative care is beneficial for patients. Slowly, we're getting involved more sooner in people's illness trajectory, but most people don't know that. So there's a lot of taboo around involving palliative care or fears surrounding palliative care. But once you get beyond that and you start being involved with palliative care, we hope that you find benefit in your quality of life.
Okay, so what are the palliative care resources in the community? Catherine and I both, Catherine works at Fraser Health in Burnaby, and I mostly work in Vancouver Coastal Health. In Vancouver, North Shore, and Richmond, there are outpatient or ambulatory palliative care units. Catherine and I both work at the Nancy Chan Palliative Care Ambulatory Clinic here in Vancouver, which is located on 25th and Cambie. You'll have home care nurses as you start to require a little bit of nursing care, whether your symptoms are getting worse or you may have a wound. Those are things that the home care nurses can be involved with. We also have palliative care units in our local hospitals, and pretty well every city has a palliative care unit. In Vancouver, we have a palliative care unit at PGH. We also have one at St. Paul's. And in Burnaby, there's a palliative care unit. Royal Columbian, I believe, has a palliative care unit. So pretty well every single city has a palliative care unit. And we'll talk about what are some of the differences between the palliative care units and then hospices. Pretty well every city has hospices. In Vancouver, we actually have several hospices, and we'll talk a little bit more about that in the latter part of the presentation. The Nancy Chan Palliative Care Ambulatory Clinic, where Catherine and I both work, was actually a donor project. We had the Chan family who actually approached PGH Foundation, and they wanted to support palliative care in Vancouver. They lost their mother, Nancy Chan, who the clinic was named after, to a life-limiting illness, and they wanted to look at ways of giving back to the community. And our medical director and director at that time put forth 4 projects, and it was actually the Chan family that chose to support the ambulatory clinic. The goals of the Nancy Chan Clinic is really to allow palliative care specialists to be available to support earlier in the illness, exactly what you saw in the video, much earlier, where people are still out and about, still receiving treatment to help improve the quality of life. We wanted to reach out to support both cancer and non-cancer. At the Cancer Agency in Vancouver, they do have a pain and symptom management team, which mostly are doctors and nurses, and they do work at trying to get any symptoms under control. But we have several of your medical oncologists and radiation oncologists who actually like to refer to us because we can actually get people in sooner, and we are able to follow people closer. And we are also very connected with the home care team, so with the home care nurses. We also want to fill that gap, people with end-stage heart disease, so heart failure, kidney failure. We want to be able to also look at the non-cancer type of illness to be able to support people with good palliative care. We also want to act as a bridge between the hospitals and the community, because if people are in hospital, they go home, they worry because their family doctor may not have that understanding of what their pain and symptoms are and be able to tend to that. So we like to be able to be a bridge to be able to know that we can bring people in if they've been discharged home from hospital to know that they actually are going to get good symptom follow-up. So that's kind of the goals that we have. Other goals we have, because palliative care, as Catherine mentioned, is delivered by a team. We actually have a social worker that works with us. And our social worker looks at increasing grief and bereavement support. She provides one-to-one counseling during the sessions at the clinic, and then when the person passes away, to be able to provide support for the family and to provide supports through that one-on-one session, which is really important. Sometimes she says to the family, if you want to meet with me separately, just to have some time to express what you're really feeling, our social worker does work with our clients and families one-to-one. And we are also an education hub. So we're here today providing education for you. We also provide education for staff. And so we do, education is one of the important pieces of our mandate at our clinic. How do you access our clinic? The referral can be from your family doctor or your nurse practitioner. You can get a referral from your specialist, whether it's your oncologist, your urologist. The one for us in the Nancy Chan, you actually have to be a resident of Vancouver. If you live in Richmond, there is another palliative care outpatient clinic, and also in the North Shore, there is another outpatient clinic. If you're in the Fraser Valley, I don't believe they have any ambulatory palliative care clinics at this point. Okay, Catherine, over to you.
And I'll just say, like, we're talking about the resources, but usually also if you're interested and you don't remember exactly the details of what we've talked about in the presentation, usually your oncologist, your urologist, your radiation oncologist are good people to ask of how to access palliative care services. Usually people ask first for symptom management, so that's also a good route to go through. So why would you be referred to palliative care? Well, early referrals for upstream planning of the disease. So as Ingrid was saying, you have had a talk about advanced care planning. So I won't give too much details, but that's something that we would be able to offer to kind of look at the bigger picture and make sure that to offer support and planning upstream for what's to come. One of the big sources of referrals is uncontrolled symptoms related to your disease. So with prostate cancer, you might have some urinary symptoms, urgency. Some people have pain related to their prostate cancer. So those would be common symptoms where you would get referred to us. And really our training as palliative care specialists is in symptom management. So we're experts in managing pain, and we have a lot of tools in our toolbox to be able to do that. And that other specialists in your care team might be less familiar with. So for uncontrolled symptoms, I think we're really the best equipped to help you with those issues. As Ingrid was saying, we also offer psychosocial support for yourself and your loved ones by working as a team with a social worker or a counselor. Again, advanced care planning and resources, and grief and bereavement counseling and follow-up. So as a team with Ingrid, with a palliative care physician, with our social worker, we're really able to offer you that multifaceted approach to increase your quality of life. And how the clinic works is it's embedded in the Vancouver Community Health System. So we're part of the bigger umbrella of what palliative care is about, because I think a lot of people associate palliative care or think palliative care is a synonym to hospice, but really palliative care is a big umbrella term of people that care about increasing your quality of life. And then there's different ways to do so, and some are appropriate at different stages of your cancer. So we're part of the Vancouver Coastal Health System. We see new patients. So new patients are seen by 3 disciplines at the clinic. So again, the nursing, the medicine, and the social worker. And communication of assessment and plan is documented and sent back to your doctor. So we work really closely with the people that refer you. And then we keep in touch with your oncology team, but also with your family doctor to make sure that everybody's on board with the plan and we really work as a team. So what does a clinic visit look like? Upon arrival, you and your family will fill out something that's called the Edmonton Symptom Assessment Scale. And it's really just a 10-item list of your symptoms, just so we get a better idea of what's been bothering you these days. And the Canadian Problem Checklist, which is more about psychosocial things that have been bothering you. So are you anxious? Are you having financial issues related to maybe stopping work with your cancer or other psychosocial issues? And then you and your family will meet with the medical team and the nursing team. So usually on a typical day, let's say you would come on to Zoom during the pandemic and meet with Ingrid and I first. And then we would negotiate a plan of care together. And maybe we would refer you also to our social worker for follow-up. There you go. So the next step is meeting our social worker. And then once we've kind of cleared the medical side of things or started things going on the symptom side of things, our social worker can help with emotional support, practical support with things like wishes, advanced care planning, wills, things like that. And also then afterwards, she can also do bereavement counseling and family counseling. And then for follow-up appointments, really we see how unwell you're feeling and we make a plan depending on your symptoms. So it's very individualized. So we'll talk about what makes sense in terms of follow-up. Usually we see people, if medications are added or we're actively changing things, usually within 1 to 2 weeks. So fairly close follow-up. Once the symptoms are more stable, but we just really want to touch base to make sure things aren't changing, maybe we'll see you every month or as needed. And same thing for the social worker. It's an on individual basis that she'll see how often you need to meet to provide the best support. And of course, in times of COVID, the clinic are done virtually via Zoom or FaceTime or telephone. We adapt to your level of skills. And you're asked to come in if we need to do a physical exam or a more complete assessment. And obviously, our clinic follows the protocols for PPE and COVID safety. Sorry, Ingrid, cut me. I can't see the page's number, so I don't know when you're...
I'm up.
Okay.
Yeah. So I would like to talk a little bit about the community health resources. So I mentioned home care nursing, and home care nursing is a referral done to the local health units. Usually it can be made by anyone, but you can ask your specialist or your family doctor or nurse practitioner to actually make the referral. I call the home care nurses the quarterbacks of the systems. They actually get in there, they assess, they see what's going on. They can bring in an occupational therapist, a physiotherapist, they could bring in a dietitian. They have access to the palliative care unit beds. There's hospice beds. And in Vancouver and Richmond, so Vancouver Coastal Health, we have shift care nurses. So people that actually want to be at home in the last days of life, we actually have 24-hour nursing care that we can put in to be able to keep people at home if they want to have a home death. The home care nurses usually check in depending on need. If you had a wound, they can come every day and dress that wound. They can come twice a week. They can come once every week. And every month if things are going relatively well. So it really depends on what's happening with your health issues at that time. In Vancouver Community, we work very, very closely. We have a Vancouver Home Hospice Palliative Care Service team, which we as a Nancy Chan Clinic are part of. And we work very closely with your GPs or your family physicians or your NPs and the home care nurses. Your family doctors are the primary care team along with your home care nurses. And in Vancouver, our home hospice team, we have the 3 branches. So Catherine and I, we see people that are still able to get out, that are more mobile, more ambulatory. So we have the Nancy Chan Palliative Care Ambulatory Clinic. When things start to change and people are no longer able to get out, or it's a real struggle to get out, they're pretty well bedbound, we can ask our colleagues who are also palliative care physicians and nurse specialists. they can actually come into your home and do a visit and work closely with the home care nurse, and they will be in touch with your family doctor. So our team kind of transitions more to the care at home team. And then if you know anyone that's in a nursing home, we actually have a specialized consultation team with a nurse and one of our doctors who actually cover the 37 long-term care facilities in Vancouver. So as you can see, our team has a huge mandate from people that are more earlier in their disease all the way to the end when someone's at home, and then eventually maybe needing palliative care units or hospices. And Catherine works at the palliative care unit, so I'm going to let her talk a little bit about the palliative care units.
Yeah, so what a palliative care unit is a ward on the hospital where we provide palliative care. So when somebody is admitted and usually goes through the emergency room, we look at what's the best place for them to be in the hospital. So if they need surgery, they go on a surgical ward. If they have acute medical issues, they go on a medical ward. If bad symptom control is the main reason why they're at the hospital, maybe a good place for them to go is the palliative care unit. So when we have people, let's say I take an example of a prostate cancer patient, some people with prostate cancer eventually get bone cancer as well. And some of those bone metastases can cause severe pain. So people can come in with pain, and that's really the main reason why they're in the hospital. And so we might offer to admit them on the palliative care unit because the doctors in charge of that ward are people like myself that have expertise in managing pain. So then we would be able to offer them support with that regard and probably be the best place in the hospital to take care of their pain. Also, we're able to do certain treatments for pain that we can't do in other places in the hospital, so a bit more advanced treatment because our nurses are trained in that as well. Yeah, so it's a place where we work as a team. So you have access to a palliative care social worker, palliative care nurses that have expertise in symptom management. So it might be the best place if that's really the issue. And when do you need a PCU, a palliative care unit bed, when symptoms, again, are not well managed at home? Also for complex psychosocial issues. So sometimes people have been in the hospital, but then it seems like they're too sick to go home, or maybe their caregiver is having a hard time coping. And there's just a lot of psychosocial issues. Because we work as a team with a social worker and we're used to kind of facing those issues that come up with serious illness, we might transfer you from your medical ward to the palliative care unit to help you support with that. And something that's really helpful also is that as we get to know you as a palliative care patient, we can also do something which is a direct admission to the palliative care unit. So instead of going through the emergency room, because we know you, if things aren't going well at home and you're experiencing more symptoms like sudden nausea and vomiting or sudden pain, and things that you think would need hospital management, we can usually bypass the emergency room and you can be admitted directly on our unit. So instead of staying in the emergency room for a while, you would be brought up either by ambulance, or some people literally walk up on our unit and are admitted directly to the palliative care unit. And that works because we know the home care nurses, we know the people at the Nancy Chan clinic. So Ingrid and I could call up a doctor at the VGH and say, we're seeing this patient today in our clinic and he's really not doing well. Do you have a bed? Would it be possible to admit him directly on the palliative care unit? So a bit about the palliative care unit philosophy. We treat conditions that can be reversed. So certainly any medical conditions that can be reversed, we'll try to do that. The goal is really a short stay, so really to stabilize symptoms that are very uncomfortable and to get you home or elsewhere as soon as possible. So it's not a place where people stay for a very long time. It's a place where we have intensive care and we can really get on top of symptoms. For example, going back to pain again, because that's something we commonly treat. At home, it might take a while for us to be able to increase your pain medication until you're comfortable. Well, under a supervised setting like the palliative care unit, we can increase your pain medication very rapidly, and that makes we achieve pain control much faster than we could probably at home. And then should the person deteriorate, the goal is to support a natural death. So on the palliative care unit, one of the exceptions is that we would not offer CPR. And that depends on which unit. So for example, I know that in Surrey, they do cardiopulmonary resuscitation. So it's something that can be discussed with your hospital to see if they support that or not. But usually in palliative care units, we would not offer CPR.
Okay, so the other options that are out there is hospice. And I mentioned earlier that each city has their own hospices. In Vancouver, we have the Vancouver Hospice Society, and so there's a hospice on 31st and Granville Street. We have St. John's Hospice, which is out by in UBC. We have Cottage Hospice, which is by the PNE, and we have Mays Place, which is in the downtown east side. So those are the hospices that we have in Vancouver. In the North Shore, there's the North Shore Hospice, and in Richmond, there is the Salvation Army Rotary Hospice. Burnaby has a hospice in St. Michael's and Tri-Cities. Everywhere out there, they have a hospice. So one of the homeworks that you can do is actually find out what is the hospice in the city that you live in. The philosophy of hospice is really focused on quality of life in a home-like setting. Hospices are beautiful. They tend to be, they're not medicalized like a hospital. It tends to be a home that has been built. Each person will have a private room, and you have your, basically, it's just like a little place where you can be with your family. Families are allowed to stay overnight and be with you. The focus is really on comfort and keeping your symptoms controlled. Most people are in bed most of the day. They may be able to get up for short periods, but really they're not able to manage at home because they're needing help with going to the bathroom. They're just not able to get out of bed. So most people that go to hospice is usually within the last 3 months of life. So when you're really bedbound and not expected to have a long period of time. In hospice, we know CPR or supporting a natural death has to be signed to be in there. It's really about when that time comes, you want to go naturally and peacefully. And that's what they're there to do, is to support you to die naturally and peacefully. Okay, I think that's you, Catherine.
Yeah, so we're talking about, again, I go back to the umbrella of palliative care. So like we saw in your journey with cancer, there's different types of palliative care that might be appropriate for you. So earlier at the time when you're diagnosed with cancer and you need maybe just help with symptom management, but you're really not anywhere close to end of life, something like the ambulatory clinic might be a good way to access palliative care. So for symptom management and psychosocial support. And once you start maybe losing a bit of function or being needing more help at home, maybe involving the home care nursing is something that you could add on to your palliative care team. And so the healthcare nurses can come home, monitor your symptoms, offer nursing care, help with personal care. Palliative care units fit also under the big umbrella when you're having acute crisis. So you're having very severe symptoms that can't be managed by just changing a few things at home when you really need to be admitted to the hospital. And then hospice is really for the end of life when, like Ingrid was saying, typically you have 3 months or less to live, and you go there for having quality of life in your end of life and having that support. I don't know if did we talk about I can't remember if we talked about the consultation service, Ingrid?
No.
Okay, so I'll add something under that umbrella as well. Something that would also be in the early phase of palliative care involvement would be something called a palliative care consultation team. And that's when you're admitted to the hospital. Let's say you would still want resuscitation if your heart were to stop, or you would still want to go to the intensive care unit. You won't be able to go on the palliative care unit, but you might be able to be seen, actually you will be able to be seen by the palliative care consultation team. So when you're on another ward, either a medical or a surgical ward, you could ask to be seen by the palliative care team, and then they will come to you and give some advice to your treating team about symptom management or psychosocial management. So that's something that you could advocate for yourself. Let's say you're finding that your pain is not well controlled on another ward, to ask for palliative care to be involved.
And most hospitals have a palliative care consult team. So I know the Lionsgate does, Richmond does, Burnaby does, Royal Columbian does, Eagle Ridge does. So a lot of them have
Yeah,
consultations.
St. Paul's, Vancouver
Yeah.
General. So what do you need to know now? Think about some of the things you have learned through your advanced care planning session and really ask yourself, what are your wishes when your condition starts to change? And those are questions that you might want to start thinking about. And then really looking at where you're at in that trajectory of you think palliative care is relevant for you now, or is that something that you'll need down the road? But just knowing kind of where we fit in, that we can be included as early as your diagnosis of cancer, or we could be included very late depending on what your needs are.
So I had emailed Len and Norm the early conversation flyer, which is called What Matters Most. And I believe those have been sent out to you. Yes, perfect. So this is something that was adopted from Ariadne Labs, and it's a huge Vancouver coastal initiative. Is really finding out what matters most to you. And you can see there's questions. It helps starts conversations, so you can actually sit down and talk with your loved ones about what your wishes are so that they're aware. And it's important to share this with your providers. Share it with anyone that's involved with your care so that we actually know what your wishes are, because as things start to change, we want to check in and say, hey, 6 months ago, these were your wishes. This was important to you. Is that still so now? Now that 6 months later, let's say you're in the hospital, things have changed. Are these still your wishes now? So it's a really good way to start some advanced care planning conversations and finding out what your wishes are. So take some time. It's important to share it also with your family doctor, because your family doctor tends to be very, very involved in your care. Maybe not as much now if you're being followed by certain specialists. Share it with your specialist. And we actually give out this flyer when people come to the Nancy Chan Clinic, just so that we can find out what those wishes are, so we can dialogue with the rest of your healthcare team. So once you have this completed, I mentioned sharing it with your team and your specialists. And if you happen to end up in the hospital, bring that with you so that people are aware that you have been giving some thought to your wishes, and share it with the healthcare team in the hospital, because they would often look at looking and having conversations about your wishes before they decide what the next steps are.
Yeah, so in summary, each city has its own community health resources or own palliative care setups. So it's important to check with your family doctor, your nurse practitioner, your oncologist, your medical team to see what resources are available to you. And really, we hope this presentation and this conversation is just got you thinking about early palliative care. Is this something that you and your family might benefit from? And we hope that we made it a bit less daunting or scary, and really, that we were able to show that it really has been, it's really strongly supported by evidence. You seem to be a group that cares about evidence-based, as we saw with the study presentation earlier. So it really is supported by evidence that the earlier you involve palliative care, the better your symptoms are controlled, the better you can tolerate your cancer treatments, and the better your quality of life is. So we hope that's something you might think about in the future. And also think about your wishes and what you'd like as things that start changing in your future are really what matters most. So just starting to have those conversations and maybe just those reflections. And thank you so much for joining us. So here's a quote by Atul Gawande, who's a general surgeon, but very interested in how society has adapted to death and dying in the last 50 years. So he says, "You may not control life's circumstances, but getting to be the author of your life means getting to control what you do with them." So we really wanted to empower you to get the best care you can for yourself.
So thank you for having us today. And I believe we have some time for questions from your group.
Thank you ever so much, Ingrid and Christina. It's very, very informative. I'm really surprised how this links with advanced care planning.